The history of the lobotomy, a journey through medicine's darkest procedure. Welcome. Settle into comfort, let your body relax, and prepare for a journey through one of medicine's most controversial chapters. Tonight, we'll explore the rise and fall of the lobotomy, a procedure that promised to cure mental illness but left thousands damaged, diminished, and forever changed. This is a story that spans less than a century, from the 1930s to the 1960s, yet in that brief time, tens of thousands of people underwent an operation that would sever connections in their brains, fundamentally altering who they were. It's a tale of desperation and hope, of ambition and hubris, of suffering patients and the doctors who believed they were helping. Don't worry about following every detail. Let the words flow over you like a gentle stream. If you drift away before the story ends, that's perfectly fine. That's what we're here for. Close your eyes if you'd like, take a deep breath, and let's begin in the early decades of the 20th century, when psychiatry was searching desperately for answers. The problem: mental illness in the early 1900s. To understand why lobotomy emerged and why it spread so rapidly, we must first understand the desperate state of psychiatric care in the early 20th century. Mental institutions were overflowing with patients for whom medicine had no effective treatments. These were not the clean, therapeutic facilities we might imagine today, but often overcrowded, underfunded warehouses for people society didn't know how to help. Patients with severe mental illnesses, schizophrenia, severe depression, obsessive-compulsive disorder, violent psychoses, were often confined for years or decades. Some remained institutionalized their entire lives. The treatments available were limited and often brutal. There was hydrotherapy, where patients were subjected to alternating hot and cold water, sometimes for hours. There was insulin shock therapy, which induced comas. There was the rest cure, which involved weeks of forced bed rest and isolation. Restraints were common. Patients deemed dangerous or uncontrollable were placed in straitjackets, tied to beds, or locked in padded cells. These weren't punishments in the minds of the staff, but necessary measures to protect patients from harming themselves or others. Still, the reality was that thousands of people lived confined, restricted, with little hope of improvement or release. The families of these patients suffered too. They had watched their loved ones change, become unrecognizable, sometimes violent or self-destructive. They had exhausted every option, tried every available treatment, and still their family members remained ill, often growing worse. The emotional and financial toll was enormous. Many families were bankrupted by the cost of long-term institutional care. Psychiatrists and neurologists of the era were acutely aware of their helplessness. They had studied the mind, had developed elaborate theories about the causes of mental illness, but they had no reliable cures. Patients came to them desperate for help, and doctors could offer only containment, not healing. This professional frustration cannot be overstated. Imagine dedicating your life to helping people, only to watch them suffer without being able to provide meaningful relief. Into this desperate situation came an idea: what if mental illness was fundamentally a problem of the brain's physical structure? What if, by surgically altering the brain, you could cure psychiatric conditions? It was a radical notion, but given the lack of alternatives and the severity of suffering, it found a receptive audience. The brain was still largely mysterious in the early 20th century. Scientists understood some of its basic anatomy and had mapped a few functional areas, but the intricate workings of thought, emotion, and personality remained opaque. The idea that you could cut into this organ and specifically target the sources of mental illness was both audacious and, to many, deeply troubling. The precursors: early brain surgery. Brain surgery itself was not new. Surgeons had been operating on brains for decades, primarily to remove tumors, drain abscesses, or repair damage from injuries. These operations were dangerous and often fatal, but they established that the brain could be accessed surgically, that people could survive having their skulls opened and brain tissue manipulated. Some earlier work had suggested that altering brain tissue might affect behavior and personality. In the late 19th century, a Swiss psychiatrist named Gottlieb Burckhardt had performed surgery on 6 patients with severe mental illness, removing portions of their cerebral cortex. The results were mixed and disturbing. Some patients seemed calmer, but they were also clearly damaged, their personalities flattened, their capabilities diminished. One patient died shortly after surgery. The medical community largely rejected Burckhardt's work, and he abandoned the experiments. But the idea persisted at the margins of medicine. If removing brain tissue could change behavior, even if the changes weren't entirely positive, didn't that suggest that mental illness was indeed rooted in brain structure? Couldn't a more refined approach, targeting the right areas with greater precision, produce better results? In the 1920s and early 1930s, neuroscience was making significant advances. Researchers were mapping the brain's functions with increasing detail, identifying which regions controlled movement, sensation, language, and other capabilities. These maps were crude by modern standards, but they represented real progress in understanding how the brain worked. A series of experiments on primates provided what would become crucial, and tragically misinterpreted, evidence. In 1935, researchers John Fulton and Carlisle Jacobson presented findings at a neurological conference in London. They had removed portions of the frontal lobes from 2 chimpanzees who had been trained to perform tasks. Before surgery, when the chimps made mistakes, they became frustrated and agitated. After the surgery, they seemed calmer, less bothered by failure. The implication seemed clear: the frontal lobes were involved in emotional distress. If you damaged the frontal lobes, you could reduce anxiety and emotional suffering. To researchers desperately seeking solutions for severe mental illness, this seemed like a crucial breakthrough. Perhaps human frontal lobes could be similarly altered to relieve psychiatric symptoms. What these researchers didn't fully appreciate, or chose to overlook, was the cost of this calmness. The chimpanzees weren't just calmer, they were changed in fundamental ways. Their personalities were flattened. Their cognitive abilities were reduced. They were less troubled, yes, but they were also less themselves. Enter Antonio Egas Moniz. Sitting in the audience at that 1935 London conference was a Portuguese neurologist named Antonio Egas Moniz. He was 61 years old, an established figure in neurology, ambitious, and always seeking the breakthrough that would cement his legacy. When he heard about the frontal lobe experiments on chimpanzees, something clicked. Perhaps this was the answer to severe mental illness. Moniz had been thinking about the physical basis of mental illness for years. He had already made contributions to neurology, developing cerebral angiography, a technique for visualizing blood vessels in the brain. He was not a psychiatrist, he had little direct experience treating mentally ill patients, but he was convinced that mental illness must have physical, observable causes in the brain. After the conference, Moniz returned to Portugal energized by a new idea. If damaging the frontal lobes could calm agitated chimpanzees, perhaps deliberately creating specific lesions in human frontal lobes could relieve the symptoms of severe mental illness. The frontal lobes, he theorized, were where abnormal thought patterns became fixed. If you could interrupt the neural connections that supported these patterns, you might be able to break the cycle of mental illness. Within months, Moniz had arranged to perform his first procedure. He couldn't operate himself. He suffered from gout that made his hands too unsteady for surgery, so he enlisted a surgeon named Almeida Lima to perform the actual operations under his direction. The collaboration between Moniz, who conceived and directed the procedures, and Lima, who wielded the instruments, would perform the first modern lobotomies. The first patient was a 63-year-old woman suffering from severe anxiety and depression. In November 1935, holes were drilled in her skull, and pure alcohol was injected into her frontal lobes, deliberately destroying tissue. The goal was to sever the connections between the frontal cortex and other brain regions, particularly the thalamus, which Moniz believed was involved in maintaining pathological thought patterns. The woman survived the operation. Moniz declared it a success, claiming her anxiety had diminished. Over the following months, he and Lima performed similar operations on 19 more patients, refining their technique with each procedure. Sometimes they injected alcohol. Other times they used a specially designed instrument called a lobotomy, which could core out cylinders of brain tissue. Moniz published his results quickly, reporting that most of his patients had improved. Some, he claimed, were cured. The medical community's response was mixed. Some were intrigued by the possibility of a surgical cure for mental illness. Others were horrified by the idea of deliberately damaging brains to treat psychiatric conditions. But Moniz was persuasive, and his professional reputation lent credibility to his claims. He called the procedure lobotomy, from the Greek words for white and cutting, referring to the white matter of the brain that was being severed. The operation would later become known by another name, one that would become infamous, lobotomy, from lobe and cutting. And while Moniz would eventually win a Nobel Prize for his work, the true cost of what he had begun would take decades to fully reveal itself. The procedure crosses the Atlantic. News of Moniz's lobotomy spread through the international medical community, appearing in journals and discussed at conferences. Most physicians remained skeptical, but in the United States, one man saw not just promise but destiny in this radical procedure. His name was Walter Freeman, and he would become the most prolific and controversial lobotomist in history. Walter Freeman was a neurologist in Washington, D.C., a man of boundless energy and ambition. Born into a prominent medical family, he had always felt pressure to achieve something significant, to make his mark on medicine. When he read about Moniz's work in 1936, he immediately recognized its potential. Here was a procedure that could address the crisis of overflowing mental institutions, that could offer hope to thousands of suffering patients and their families. Freeman was not a surgeon. Like Moniz, he lacked surgical training, so he enlisted a colleague, neurosurgeon James Watts, to perform the actual operations. Together, they would perform their first lobotomy in September 1936, less than a year after Moniz's initial procedures. The patient was a 63-year-old woman from Kansas, suffering from agitation and insomnia. She had tried every available treatment without success. The operation followed Moniz's technique. Watts drilled holes in the woman's skull, on both sides of her head, while she was under general anesthesia. Through these holes, he inserted a surgical instrument that severed connections in her frontal lobes. The procedure took several hours. The woman survived, and Freeman declared her improved, calmer, less agitated, able to sleep. Encouraged by this initial result, Freeman and Watts continued operating. By the end of 1936, they had performed 20 procedures. Freeman meticulously documented each case, taking detailed notes and photographs. He was convinced he was pioneering a revolutionary treatment, and he wanted the world to know about it. But Freeman wasn't satisfied with simply replicating Moniz's technique. He wanted to refine it, make it faster, more accessible, more widely available. The standard procedure required a neurosurgeon, an operating room, general anesthesia, and significant recovery time. Freeman dreamed of a simpler method, something that could be performed quickly, inexpensively, in settings outside major hospitals. Freeman was also a showman, a quality that would prove crucial to lobotomy's spread. He understood that medicine was not just about technique but about persuasion, about convincing other doctors, hospitals, families, and patients that this radical procedure was not only safe but necessary. He gave lectures, wrote articles, appeared before medical societies, always with photographs and case studies designed to demonstrate lobotomy's effectiveness. His message resonated because the need was so desperate. America's mental hospitals were overwhelmed. The population of psychiatric institutions had been growing for decades, and by the late 1930s, more than 400,000 people were confined in state mental hospitals. These institutions were chronically underfunded, understaffed, and overcrowded. Patients often received minimal care, spending their days idle, sometimes violent, frequently deteriorating rather than improving. For the superintendents of these institutions, for state governments struggling with the costs, for families watching loved ones waste away in asylums, Freeman's lobotomy offered something precious: hope. The promise that severe mental illness could be cured, not just managed. That patients could return home. That the economic and emotional burden could be lifted. This hope, however false it would prove to be, was intoxicating. Freeman and Watts refined the technique. Throughout the late 1930s and early 1940s, Freeman and Watts performed dozens, then hundreds of lobotomies. They published their results in medical journals and in 1942 produced a textbook, Psychosurgery, which detailed their techniques and cases. The book presented lobotomy as a legitimate, scientifically grounded treatment for severe mental illness. Their technique evolved during this period. They settled on a method called the precision method or Freeman-Watts standard technique. The patient would be anesthetized, and Watts would drill holes on both sides of the skull, just above and behind the temples. Through these holes, he would insert a flat surgical instrument called a lobotomy, carefully cutting into the white matter of the frontal lobes. The goal was to sever the connections between the prefrontal cortex and the thalamus, based on the theory that these connections maintained pathological thought patterns and emotions. By interrupting these connections, they believed they could relieve symptoms of mental illness. The procedure typically took between 1 and 2 hours, and patients usually remained hospitalized for 1 to 2 weeks afterward. Freeman and Watts claimed that about 63% of their patients improved after the operation. Some patients, they said, recovered enough to leave institutions and return to their families. Others showed reduced agitation, less violent behavior, decreased anxiety. These results, presented in professional publications and lectures, seemed impressive to many in the medical community. What the published results often downplayed or omitted were the complications and side effects. Some patients died from the surgery. Bleeding in the brain, infections, or other surgical complications could be fatal. Others survived but developed seizures, which sometimes continued for the rest of their lives. Many patients experienced what Freeman called social flatness, a reduction in emotional responsiveness, initiative, and personality depth. Some patients emerged from lobotomy profoundly changed, not just calmer but diminished. They might lose the ability to plan or show initiative. They might become childlike, requiring supervision for basic activities. They might lose the spark of personality that had made them who they were. Family members sometimes reported that the person who returned from surgery was not really their loved one anymore, but someone different wearing a familiar face. Freeman acknowledged these effects but characterized them as acceptable trade-offs. A patient who was emotionally flat but no longer violently psychotic was, in his view, improved. A person who required supervision but was no longer tormented by obsessive thoughts was better off. He saw lobotomy as reducing patients to a more manageable state, even if that state involved significant losses in cognitive and emotional function. James Watts was more troubled by these outcomes. He was the one actually performing the surgeries, the one who saw the immediate results, and he grew increasingly concerned about the damage being done. But Freeman was the driving force, the visionary, the one with the missionary zeal to spread lobotomy as widely as possible. And Freeman's vision was about to become far more radical. The ice pick lobotomy. In 1945, Freeman learned about a technique developed by an Italian physician named Amaro Fiamberti. Fiamberti had performed lobotomies by entering through the eye sockets rather than drilling through the skull. The approach was faster and didn't require surgical facilities. Freeman was immediately intrigued. This could be the key to making lobotomy widely accessible, simple enough to perform outside traditional surgical settings. Freeman began experimenting with this approach, which would become known as the transorbital lobotomy, or, more colloquially, the ice pick lobotomy. The procedure was shockingly simple and brutal. The patient would be rendered unconscious using electroshock therapy, no general anesthesia required. While the patient was unconscious, Freeman would insert a thin surgical instrument called an orbitoclust up through the eye socket, above the eyeball, into the brain. The instrument, which resembled an ice pick, hence the nickname, would be inserted into the brain and then swept side to side, severing connections in the frontal lobes. Freeman would insert the orbitoclust on both sides, performing the same sweeping motion. The entire procedure took only a few minutes. No operating room required. No neurosurgeon needed. Freeman could perform it himself. He first attempted this procedure in 1946, on a patient in his office. The operation was successful in the sense that the patient survived. Freeman was elated. He had developed a method that was quick, inexpensive, and simple. It could be performed in mental hospitals, in outpatient clinics, anywhere there was electricity for the electroshock and a physician willing to wield the orbitoclust. James Watts was horrified when Freeman showed him the technique. This wasn't surgery in any respectable sense, it was brutal, imprecise, dangerous. Watts felt it crossed ethical lines and represented a betrayal of surgical principles. The two men had increasingly bitter arguments. Watts insisted that lobotomy, if performed at all, should only be done in proper surgical settings with appropriate safeguards. Freeman argued that the urgent need justified the streamlined approach. In 1948, their partnership ended. Watts refused to participate in transorbital lobotomies, and Freeman refused to limit himself to the more conservative surgical approach. They parted ways, with Freeman now free to pursue his vision without restraint. He would spend the next 2 decades traveling across America, performing thousands of transorbital lobotomies, becoming a one-man lobotomy crusade. Freeman purchased a van, which he called his Lobotomobile, and drove from state to state, visiting mental hospitals and offering to perform lobotomies. Hospital administrators, desperate to reduce overcrowding and cut costs, often welcomed him. Freeman would sometimes perform dozens of procedures in a single day, moving from patient to patient with assembly line efficiency. The transorbital technique allowed for this volume. No need for lengthy operations, for recovery rooms, for extensive postoperative care. Patients would be shocked unconscious, lobotomized in minutes, and would wake up shortly afterward with black eyes but able to walk. Many could be discharged from institutions within days or weeks, their beds freed for other patients. The spread of lobotomy. Freeman's evangelism for lobotomy, combined with the desperate conditions in mental hospitals and the lack of alternative treatments, led to explosive growth in the procedure's use. In the late 1940s and throughout the 1950s, lobotomies were performed at an increasing rate across the United States and in many other countries. Hospitals that had been overwhelmed with chronic patients saw lobotomy as a solution to an impossible problem. State governments, struggling with the costs of maintaining overcrowded institutions, saw it as a way to reduce populations and expenses. Some administrators openly discussed lobotomy in economic terms, the cost of the operation versus the cost of decades of institutional care. Families, desperate for any hope, often consented to the procedure without fully understanding what it entailed or what the consequences might be. Doctors and hospitals presented lobotomy as a cure, or at least a significant improvement, downplaying the risks and side effects. Consent forms were often minimal, and in some cases, especially with institutionalized patients who had been committed involuntarily, no meaningful consent was obtained at all. The procedure spread beyond treatment of severe mental illness. Freeman and other practitioners began advocating lobotomy for an increasingly wide range of conditions. depression that didn't respond to other treatments, severe anxiety, obsessive-compulsive disorder, chronic pain, even criminal behavior and homosexuality, which was classified as a mental illness at the time. Some lobotomies were performed on children, some as young as 4 years old. These children, often institutionalized for developmental disabilities or behavioral problems, underwent the same procedure as adults, with the same permanent effects. The justification was that intervening early might prevent a lifetime of suffering and institutionalization. By 1949, Antonio Egas Moniz was awarded the Nobel Prize in Physiology or Medicine for his development of leucotomy. The award was controversial even at the time, with some in the medical community objecting that not enough time had passed to fully evaluate the procedure's safety and effectiveness. But the Nobel Prize lent lobotomy enormous prestige and credibility, suggesting that the world's most respected medical authorities endorsed the operation. Famous cases: Rosemary Kennedy. Among the thousands who underwent lobotomy, one case stands out for its tragedy and the light it sheds on how the procedure was used, even on those from privileged families. Rosemary Kennedy, sister of future President John F. Kennedy, was lobotomized in 1941 at the age of 23. Her story reveals how even wealth and social standing couldn't protect someone from this procedure. Rosemary was born in 1918, the third child and first daughter of Joseph and Rose Kennedy. From early childhood, it was clear that she was different from her siblings. She struggled academically, had difficulty with coordination, and her emotional development lagged behind that of her brothers and sisters. Today, she might have been diagnosed with a mild intellectual disability or a learning disorder. In the 1920s and 1930s, such conditions were poorly understood and often hidden by families, especially prominent families concerned about their reputation. As Rosemary grew into adolescence and young adulthood, her behavior became more challenging. She experienced mood swings, could be difficult to manage, and showed interest in boys in ways that alarmed her strictly Catholic family. There are suggestions in historical accounts that she may have been sexually active, which would have been considered scandalous for an unmarried woman of her social standing at that time. Joseph Kennedy, the family patriarch, was deeply concerned about what he saw as Rosemary's deterioration and the potential embarrassment she might cause the politically ambitious family. He learned about lobotomy through his social connections and the publicity surrounding the procedure. Freeman and others were presenting it as a cure for precisely the kind of problems Rosemary displayed: emotional instability, difficulty with impulse control, inappropriate behavior. In November 1941, without consulting his wife Rose or telling most of his children, Joseph Kennedy arranged for Rosemary to undergo a prefrontal lobotomy. She was taken to George Washington University Hospital, where the procedure was performed by Walter Freeman and James Watts. This was before their split, when they were still using the more precise surgical approach rather than Freeman's later ice pick method. The operation was a disaster. Rather than improving, Rosemary was left profoundly disabled. Her mental capacity, which had been limited but functional, was now severely impaired. She could no longer walk or speak intelligibly. She required full-time care for the rest of her life. The young woman who had been able to read and write simple sentences, who had attended special schools and could function with supervision, was reduced to a state of complete dependence. The Kennedy family hid what had happened to Rosemary for decades. She was sent to an institution in Wisconsin, where she lived for the rest of her life. The family told friends and the public that she was pursuing a life of religious contemplation or that she was working with disabled children. It wasn't until the 1980s that the truth about her lobotomy became public knowledge. Rosemary's case is particularly tragic because she likely wasn't severely mentally ill in the way that most lobotomy patients were. She had developmental challenges and behavioral issues, but she wasn't psychotic or violent. Yet the same procedure that was supposed to calm violently disturbed patients was used on her, with catastrophic results. She lived until 2005, dying at age 86, having spent more than 60 years in institutional care because of a procedure that was supposed to help her. What actually happened during lobotomy? To truly understand lobotomy's impact, we need to examine what physically happened during the procedure and what it did to the brain. When Freeman or another practitioner performed a transorbital lobotomy, they weren't removing a specific diseased area or correcting a clear anatomical problem. They were blindly severing connections in the frontal lobes, the parts of the brain responsible for personality, decision-making, and emotional regulation. The frontal lobes are what make us distinctively human. They're involved in executive function, planning, organizing, controlling impulses. They help us consider consequences before acting, weigh options, make reasoned decisions. They're crucial for personality, for the qualities that make each person unique. When you damage the frontal lobes, you don't just reduce symptoms of mental illness. You fundamentally alter who the person is. During a transorbital lobotomy, the patient would first receive electroshock therapy to render them unconscious. This in itself was traumatic, electric current passing through the brain, causing a seizure. While the patient was unconscious, Freeman would lift the upper eyelid and place the tip of the orbitoclast against the top of the eye socket. With a surgical hammer, he would tap the instrument through the thin bone at the top of the eye socket, driving it into the frontal lobe of the brain. Once the orbitoclast penetrated into the brain, Freeman would sweep it side to side, severing the white matter tracts that connected the frontal cortex to other brain regions. He would then repeat the process on the other side. The entire procedure took about 10 minutes. There was no way to see what was being cut, no precision, no ability to target specific neural pathways. It was crude, destructive, and irreversible. The damage caused by lobotomy was permanent. Brain tissue doesn't regenerate the way other tissues do. Once those connections were severed, they were gone forever. Some patients seemed to adapt over time, finding new ways to function, but they never recovered what had been lost. The person who existed before the lobotomy was, in a very real sense, gone. In the immediate aftermath of lobotomy, patients often appeared dazed and confused. They had spectacular black eyes from the bruising caused by the orbitoclast passing through the eye sockets. Many experienced severe headaches. Some had seizures. A small but significant percentage died from brain hemorrhages or other complications. Those who survived the immediate postoperative period often exhibited what Freeman called a frontal lobe syndrome. They were often apathetic, showing little interest in activities or people. Their emotional responses were flattened, they might not laugh or cry with the intensity they once did, or their emotional reactions might seem inappropriate or disconnected from the situation. Many lost initiative and needed to be prompted to do even basic activities like eating or bathing. Cognitive effects were common. Many patients had trouble with executive function, they couldn't plan complex activities, couldn't organize their thoughts effectively, struggled with problem solving. Some became impulsive, acting without considering consequences. Others became passive, requiring direction for even simple decisions. Memory could be affected, especially the ability to form new memories or recall recent events. Personality changes were perhaps the most disturbing effects. Family members often reported that their loved one seemed like a different person after lobotomy. Someone who had been vibrant and engaged might become passive and indifferent. A person who had been thoughtful might become impulsive. The essential qualities that made them who they were, their interests, their sense of humor, their values, could be diminished or lost entirely. The peak years, 1949 to 1952. The late 1940s and early 1950s represented the peak of lobotomy's use. During these years, approximately 5,000 lobotomies were performed annually in the United States alone. Similar procedures were being conducted in many other countries, including the United Kingdom, Scandinavia, and Japan. The total number of lobotomies performed worldwide during this peak period likely exceeded 10,000 per year. Mental hospitals embraced the procedure enthusiastically. Some institutions developed their own lobotomy programs, with staff physicians trained in the technique. Others invited traveling practitioners like Freeman to visit and perform operations. The financial incentive was clear. Lobotomized patients often required less intensive care and could sometimes be discharged, reducing the hospital's costs. The media during this period generally presented lobotomy positively. Newspapers and magazines ran stories about miracle cures, about patients who had spent years in institutions and were now living at home. These stories emphasized dramatic improvements while often ignoring or minimizing the costs. The Saturday Evening Post, one of America's most popular magazines, published an article in 1941 titled "Turning the Mind Inside Out," which enthusiastically described lobotomy as a breakthrough treatment. Medical journals published numerous studies claiming high success rates. Definitions of success varied widely and were often generous. A patient who went from violently psychotic to passively manageable was considered improved, even if they had lost significant cognitive and emotional capacity. A patient who could be discharged from an institution was considered cured, even if they required constant supervision at home. Freeman himself became something of a celebrity in medical circles. He lectured widely, appeared on television programs, and was profiled in popular magazines. He maintained meticulous records of his cases, eventually performing more than 3,500 lobotomies personally, more than any other single practitioner. He photographed his patients before and after, creating a visual archive that he used to promote the procedure. The typical lobotomy patient during these peak years was not necessarily someone with the most severe mental illness. While some were indeed chronically psychotic or violently disturbed, many were diagnosed with depression, anxiety, or what would today be considered personality disorders. Some were lobotomized for problems that would barely be considered mental illness today: women with excessive sexual desire, people who were simply difficult or nonconformist. Institutional lobotomy programs often targeted patients who were disruptive or expensive to care for rather than those most in need of treatment. A patient who was quiet but severely ill might be left alone, while a patient who was loud or combative might be lobotomized to make them easier to manage. The procedure was sometimes used as punishment disguised as treatment, a way to control difficult patients. Women underwent lobotomy at significantly higher rates than men. Some historians have suggested this reflected gender biases in psychiatry at the time. Women who were emotional, assertive, or sexually active might be seen as pathological in ways that similar behavior in men would not. Freeman himself noted that women seemed to respond better to lobotomy, by which he often meant that they became more passive and compliant. Children continued to undergo lobotomy during these years, though they represented a small percentage of total cases. The youngest patient on record was 4 years old. These children were often institutionalized for developmental disabilities or behavioral problems, and lobotomy was presented to families as giving the child a chance at a more normal life. The reality was usually quite different. Voices of survivors. While many lobotomy patients were too damaged to describe their experiences, some survivors have left accounts that provide haunting insights into what the procedure meant for those who underwent it. These voices, though rare, are crucial for understanding lobotomy's human cost. Howard Doley was lobotomized by Walter Freeman in 1960, at the age of 12. His stepmother had found him difficult and unmanageable, and Freeman agreed to perform the procedure. Decades later, Doley wrote a memoir describing his experience and his struggle to understand why this had been done to him. He described feeling that something essential had been taken from him, that he had lived his life with a piece missing, never quite whole. Doley's account is particularly valuable because he underwent lobotomy as a child and lived into the era when the procedure was recognized as harmful. He could articulate not just the immediate effects but the lifetime of consequences, the difficulty forming relationships, the struggles with impulse control, the sense of disconnection from himself and others. His memoir became an important document in the historical understanding of lobotomy's impact. Other survivors described the immediate postoperative experience as terrifying and confusing. They woke with severe pain, profound disorientation, and no clear understanding of what had been done to them. Some described feeling that they had lost access to parts of themselves, that they could no longer experience emotions with the depth they once had, or that they couldn't think in the ways they had before. Family members of lobotomy patients sometimes described the aftermath more eloquently than the patients themselves could. They spoke of loved ones returning home but not really returning, present physically but absent in essential ways. A husband might look at his lobotomized wife and see a stranger. A mother might care for her lobotomized child and mourn the person they had been. These personal accounts, collected over decades, paint a picture very different from Freeman's optimistic reports and success statistics. They reveal lobotomy not as a cure but as a tragedy, not as liberation from mental illness but as a different kind of imprisonment, trapped in a brain that had been deliberately damaged, in a self that had been forcibly diminished. Growing concerns within medicine. Even during lobotomy's peak years, not all physicians were convinced. A vocal minority within the medical community raised serious concerns about the procedure, questioning both its effectiveness and its ethics. These dissenting voices, though initially marginalized, would eventually contribute to lobotomy's decline. Some neurologists and psychiatrists pointed out that the evidence for lobotomy's success was largely anecdotal and methodologically flawed. Freeman and other practitioners rarely conducted controlled studies. They didn't compare lobotomized patients to similar patients who received other treatments or no treatment at all. Their follow-up was often limited, focusing on short-term outcomes rather than long-term consequences. And their criteria for success were subjective and generous. Critics also noted that many published reports came from practitioners who had professional and financial stakes in lobotomy's success. Freeman, in particular, had built his career on the procedure. His reputation depended on lobotomy being seen as effective. This conflict of interest raised questions about whether the reported results could be trusted. The neurologist Morris Pressman published a critical review in 1950, examining the claims made about lobotomy's effectiveness. He found that the reported success rates varied wildly depending on who was doing the reporting and how they defined success. More rigorous studies, he noted, showed much lower improvement rates and much higher complication rates than Freeman and others claimed. Some psychiatrists questioned the fundamental premise behind lobotomy. Even if the procedure did reduce certain symptoms, was this because it treated mental illness, or simply because it damaged the brain so severely that patients became incapable of expressing distress? A patient who was apathetic and passive might seem improved to hospital staff, but had their suffering actually been relieved, or had they simply lost the capacity to feel and express it? There were ethical concerns as well. How could patients with severe mental illness give meaningful informed consent to a procedure that would permanently alter their brains and personalities? Many lobotomies were performed on involuntarily committed patients who had no say in their treatment. Even when families consented on behalf of patients, were they given accurate information about the risks and likely outcomes? Some critics pointed out that lobotomy was being used disproportionately on marginalized populations, institutionalized patients, prisoners, people from lower socioeconomic classes, women who violated social norms. This suggested that the procedure was serving social control functions as much as therapeutic ones, making difficult people manageable rather than making sick people well. Professional medical organizations were slow to take positions on lobotomy. The American Medical Association didn't condemn it. Neither did the American Psychiatric Association. The absence of official opposition meant that individual practitioners could continue performing lobotomies without professional consequences, even as evidence of harm accumulated. The medical profession's reluctance to challenge lobotomy reflected several factors. There was genuine desperation about the state of psychiatric treatment without effective alternatives. Criticizing lobotomy felt like abandoning patients to hopeless institutionalization. There was also professional courtesy and reluctance to publicly attack colleagues. And there was the influence of prominent figures like Freeman, who used their reputations and connections to marginalize critics. But the critical voices persisted, publishing case studies of particularly bad outcomes, pointing out methodological flaws in success claims, and raising ethical questions. These critics were laying the groundwork for the eventual recognition that lobotomy was not a breakthrough treatment but a medical disaster. Lobotomy around the world. While the United States saw the highest absolute numbers of lobotomies, the procedure spread internationally, with each country developing its own practices and encountering its own controversies. The story of lobotomy is not just American, it's a global medical tragedy. In the United Kingdom, lobotomy was adopted more cautiously than in the United States, but still widely practiced. British psychiatrists tended to use more conservative surgical approaches than Freeman's transorbital method, and there was more emphasis on careful patient selection. Still, thousands of British patients underwent the procedure during the 1940s and 1950s. The Scandinavian countries, particularly Sweden, embraced lobotomy with disturbing enthusiasm. Sweden performed more lobotomies per capita than any other country. Between 1944 and 1966, approximately 4,500 Swedish patients underwent the procedure, a remarkable number for a country with a population of only 7 or 8 million at the time. Most were women, and many were diagnosed with conditions we would consider mild by today's standards. The Swedish experience with lobotomy has been the subject of significant historical investigation. Records reveal that the procedure was used on people with depression, anxiety, and even chronic pain. Some patients were lobotomized for moral insanity, essentially, for failing to conform to social expectations. The Swedish medical establishment was slow to acknowledge the harm caused, and official apologies didn't come until the 21st century. Japan also adopted lobotomy during the post-World War II period. Japanese psychiatrists learned the technique from American occupation forces and incorporated it into their own practices. Cultural factors shaped how lobotomy was used in Japan, with particular emphasis on reducing behaviors that disrupted family harmony or social order. The procedure continued in Japan longer than in most Western countries, with cases reported into the 1970s. The Soviet Union took a different approach. While early Soviet psychiatrists experimented with lobotomy in the 1940s, the procedure was officially banned in 1950. The Soviet authorities declared it incompatible with Pavlovian psychology, which was the official doctrine of Soviet medicine. However, this didn't necessarily mean Soviet psychiatry was more humane. Other coercive treatments continued, and psychiatric institutions were sometimes used to confine political dissidents. France, despite being home to major psychiatric institutions and research centers, remained relatively skeptical of lobotomy. French psychiatrists were more influenced by psychoanalytic traditions and were less likely to embrace biological interventions like lobotomy. The procedure was performed in France but never achieved the popularity it reached in Anglo-American countries. In many countries, including the United States, lobotomies were performed on prisoners and people in correctional institutions. This was particularly controversial because consent was even more problematic in these settings. Was a prisoner's agreement to undergo lobotomy truly voluntary when the alternative might be indefinite confinement? Some prisoners agreed to the procedure hoping it would lead to their release, only to find themselves damaged and still confined. Veterans' hospitals also performed lobotomies, particularly in the United States. Soldiers returning from World War II with what we now recognize as PTSD, then called shell shock or battle fatigue, were sometimes subjected to the procedure. The VA hospital system conducted thousands of lobotomies during the late 1940s and 1950s, contributing significantly to the total numbers. The international spread of lobotomy reveals how a medical procedure can gain acceptance across different cultures and healthcare systems despite limited evidence of effectiveness. The desperation to address mental illness, combined with the authority of medical institutions and individual practitioners, overcame skepticism and caution in country after country. The role of families. Behind every lobotomy was a family faced with an agonizing decision. Understanding how families came to consent to this procedure, and how they lived with the consequences, is crucial to understanding lobotomy's history. Many families who agreed to lobotomy for their loved ones were truly desperate. They had watched mental illness devastate someone they cared about, had tried every available treatment without success, and were facing the prospect of long-term or permanent institutionalization. When doctors presented lobotomy as a potential cure, or at least a significant improvement, families grabbed at this hope. The information families received about lobotomy was often incomplete or misleading. Doctors emphasized the possibility of improvement and discharge from institutions while minimizing or not fully explaining the risks and side effects. Consent forms, when they existed at all, were often vague about what the procedure entailed and what consequences might follow. Families rarely understood that their loved one's personality might fundamentally change, that cognitive abilities might be permanently impaired. The power dynamics between doctors and families made true informed consent difficult. In the 1940s and 1950s, medical authority was rarely questioned. Doctors were trusted figures, their recommendations followed without the skepticism and patient autonomy we expect today. When a doctor recommended lobotomy, many families felt they should defer to medical expertise, even if they had doubts or concerns. Economic factors influenced decisions. Long-term institutional care was expensive, potentially bankrupting families. If lobotomy offered even a possibility of reducing care needs or allowing the patient to return home, the financial pressure could make the procedure seem necessary. State hospitals sometimes pressured families to consent to lobotomy, suggesting it would allow discharge and implying that refusing meant abandoning their family member to indefinite institutionalization. Some families were not consulted at all. Patients who had been committed involuntarily, who had no family contact, or whose families couldn't be located might undergo lobotomy based solely on institutional decisions. In cases where patients were wards of the state, officials could authorize the procedure without family input. This was particularly common for children in orphanages or adults in long-term institutional care. After lobotomy, families faced the reality of what had been done. Some found that their loved one had indeed improved in certain ways, perhaps less violent, less agitated, more manageable. But almost always, these improvements came with costs. The person might be calmer but also emotionally flat, passive, lacking initiative. They might be easier to care for but also dependent, requiring supervision and assistance they hadn't needed before. Many families struggled with guilt. Parents questioned whether they had made the right decision in consenting to their child's lobotomy. Spouses wondered if they had betrayed their partner. Siblings felt responsible for what had happened to their brother or sister. This guilt was compounded when, as often happened, the results were clearly negative and the patient was worse off than before. Some families kept what had happened secret, ashamed of the procedure and its results. They might tell friends and extended family that their loved one was resting or recovering without explaining what treatment they had received. This secrecy isolated families, preventing them from finding support or connecting with others who had similar experiences. There were families who felt they had made the right choice, who believed that despite the costs, lobotomy had helped their loved one. These families typically focused on specific improvements: reduction in violent behavior, decreased agitation, ability to live at home rather than in an institution. Whether these improvements justified the losses is a question each family had to answer for themselves, often struggling with it for the rest of their lives. Walter Freeman's crusade continues. While criticism of lobotomy was growing within parts of the medical community, Walter Freeman remained undeterred. If anything, opposition seemed to energize him, to confirm his sense that he was a visionary fighting against conservative medical orthodoxy. Throughout the 1950s, he continued performing transorbital lobotomies at a remarkable pace. Freeman kept meticulous records of his cases, photographing patients before and after surgery, documenting their symptoms and outcomes. These records, which still exist, provide a disturbing window into his practice. The photographs show patient after patient with the characteristic black eyes of recent transorbital lobotomy, many looking dazed or confused, their expressions flat and distant. He continued to innovate, or at least to experiment. He tried variations on the basic transorbital technique, adjusting the angle and depth of the orbitoclast's penetration, attempting to refine the procedure. But these modifications were based on intuition and trial and error rather than scientific understanding. He was still operating blind, severing connections in the brain without any way to see what he was cutting or to predict the specific effects. Freeman developed a ritual around his procedures. He often performed them without surgical gloves, claiming he had more control that way. He would sometimes juggle the orbitoclasts or perform other theatrical gestures, treating the operations as performances as much as medical procedures. This showmanship served his ego but also made his practices seem less serious, more reckless than scientific medicine should be. He took pride in his speed and efficiency, boasting about how many procedures he could perform in a day. On one occasion, he lobotomized 25 women in a single day at a West Virginia hospital. This assembly line approach to brain surgery horrified critics but was exactly what resource-strapped mental institutions wanted, a practitioner who could process large numbers of patients quickly and cheaply. Freeman's relationship with James Watts, his former partner, remained strained. Watts had gone on to a respected career in neurosurgery, while Freeman had become increasingly marginal within mainstream medicine. Watts rarely spoke publicly about their work together, perhaps regretting his role in pioneering lobotomy. The contrast between their paths illustrated the growing professional divide over the procedure, mainstream medicine moving away, Freeman doubling down. The pharmaceutical revolution begins. The beginning of the end for lobotomy came not from moral outrage or scientific refutation, but from an alternative. In the early 1950s, pharmaceutical companies began developing drugs that could treat symptoms of severe mental illness without surgery. These medications would eventually revolutionize psychiatric treatment and make lobotomy obsolete. The first breakthrough was chlorpromazine, marketed in the United States as Thorazine. French pharmaceutical researchers had initially developed it as a surgical anesthetic, but psychiatrists noticed that it had unusual calming effects. In 1952, French psychiatrist Jean Delay began using it to treat psychiatric patients and reported remarkable results. Patients with severe psychosis, violent behavior, and uncontrollable agitation became calmer and more manageable. Thorazine arrived in the United States in 1954, and its impact was immediate and dramatic. Mental hospitals that had relied on restraints, isolation, and lobotomy suddenly had a tool that could control symptoms without surgery. Patients who had been violent became peaceful. Those who had been unreachable became somewhat responsive. The medication had side effects, sometimes severe ones, but it didn't require cutting into the brain, and its effects weren't permanent and irreversible. The pharmaceutical companies promoted these new drugs aggressively, and hospitals adopted them rapidly. The appeal was obvious: medications were easier to administer than surgery, could be adjusted or discontinued if they didn't work, and didn't carry the risks of brain surgery. Within a few years, antipsychotic medications became the standard first-line treatment for severe mental illness. This pharmaceutical revolution transformed mental institutions. Wards that had been chaotic, with patients in restraints or locked in seclusion, became quieter and more manageable. Patients could participate in therapy and activities rather than being confined or sedated. Some could be discharged from hospitals, maintained on medications in outpatient settings. The medications weren't cures, but they were effective at managing symptoms in ways that made life more bearable for patients and staff. The availability of antipsychotic medications undermined the rationale for lobotomy. If symptoms could be controlled with pills, why would anyone undergo brain surgery? The answer was that they increasingly didn't. Lobotomy rates began to decline in the mid-1950s, slowly at first, then more rapidly as the effectiveness of medications became clear and additional psychiatric drugs were developed. Freeman initially dismissed the new medications, arguing that they didn't truly cure mental illness the way lobotomy supposedly did. He claimed that medications merely suppressed symptoms while lobotomy addressed root causes. But this argument became harder to sustain as evidence accumulated that lobotomy didn't cure mental illness either, it just caused brain damage that happened to reduce certain symptoms along with many other capacities. The medical community's embrace of psychiatric medications reflected not just their effectiveness but also the profession's discomfort with lobotomy. Many doctors had never been entirely comfortable with the procedure but had supported it because no alternatives existed. Once medications provided another option, support for lobotomy evaporated quickly. It became easier to acknowledge doubts and concerns that had been suppressed when lobotomy seemed like the only hope. By the late 1950s, lobotomy was clearly in decline. The number of procedures performed annually had dropped significantly. Medical schools stopped teaching the technique. Younger psychiatrists entering practice had no experience with lobotomy and no interest in learning it. The procedure was becoming a relic, something that belonged to the desperate past rather than the promising future. Notable disasters and turning points. As lobotomy declined, several highly publicized disasters and changing attitudes accelerated its fall from medical grace. These incidents revealed the procedure's dangers in ways that could no longer be ignored or minimized. One significant case involved Frances Farmer, a Hollywood actress who had been hospitalized for mental illness in the 1940s. For years, rumors circulated that she had been lobotomized during her confinement, though the evidence remains disputed. Whether or not she actually underwent the procedure, the belief that a talented, successful woman had been lobotomized and destroyed, became part of lobotomy's cultural mythology. Her story, true or exaggerated, represented the procedure's capacity to erase people, to take vibrant individuals and reduce them to shadows. In 1967, Freeman performed what would be his final lobotomy. The patient was a woman who had been his patient for many years, undergoing her third lobotomy. During the procedure, she suffered a brain hemorrhage and died. This death finally ended Freeman's long career. Hospitals that had tolerated his practice despite growing concerns now refused to let him operate. He was finished as a practicing lobotomist. Freeman's response to this final tragedy was revealing. He didn't express remorse or question whether he should have continued performing procedures that mainstream medicine had largely abandoned. Instead, he seemed to view the death as an unfortunate complication, an acceptable risk in the pursuit of treating mental illness. This lack of reflection or accountability demonstrated how deeply Freeman had committed to his belief in lobotomy, even in the face of mounting evidence of harm. The civil rights movement and changing social attitudes in the 1960s also contributed to lobotomy's decline. There was growing awareness of how psychiatric treatment had been used to control and marginalize people, particularly women, minorities, and those who didn't conform to social norms. Lobotomy came to be seen not as cutting-edge treatment but as medical violence, a tool of oppression dressed up as therapy. The anti-psychiatry movement, led by figures like Thomas Szasz and R.D. Laing, questioned the entire framework of institutional psychiatry. While their critiques were sometimes overly broad, they effectively highlighted the coercive aspects of psychiatric treatment, including lobotomy. They pointed out that mental illness had been used to pathologize normal human variation and that treatments like lobotomy were about control rather than care. Legal challenges began to emerge. Some former patients or their families sued practitioners and hospitals, claiming that they hadn't given informed consent or that the procedure constituted medical malpractice. While many of these lawsuits failed, informed consent standards were different in the 1940s and 1950s. They created legal exposure that made hospitals increasingly reluctant to allow lobotomies. Media coverage shifted dramatically. Where newspapers and magazines had once celebrated lobotomy as a miracle cure, they now published exposés revealing its dangers and limitations. Television documentaries showed the reality of lobotomized patients, not the success stories Freeman promoted, but the damaged, diminished people who populated institutions. Public opinion turned decisively against the procedure. One particularly influential book was The Myth of Mental Illness by Thomas Szasz, published in 1961. While Szasz's arguments were controversial, his critique of psychiatric coercion resonated widely. He described lobotomy as the clearest example of psychiatry's capacity for cruelty, the most extreme manifestation of medical authority used to control rather than heal. The combination of effective alternatives, professional disillusionment, legal liability, and changing social attitudes created an environment where lobotomy could no longer survive. By the late 1960s, the procedure had virtually disappeared from American medical practice. Individual practitioners might still perform occasional procedures, but the era of mass lobotomy was definitively over. Freeman's final years. After his final disastrous lobotomy in 1967, Walter Freeman's life entered a long decline. He was forced to retire from active practice, his privileges revoked at hospitals across the country. For a man who had defined himself by his work, who had performed thousands of procedures and traveled endlessly to promote his technique, this forced retirement was devastating. Freeman spent his remaining years trying to justify his life's work. He maintained detailed files on his lobotomy patients, continuing to track their outcomes decades after their procedures. He would drive across the country visiting former patients, documenting their lives, seeking evidence that his work had been worthwhile. These visits were often unwelcome. Many patients and families wanted nothing to do with the man who had damaged their loved ones. His records from these follow-up visits reveal a man increasingly unable to acknowledge the harm he had caused. He would document a woman living in a supervised group home, unable to work or care for herself, and consider this a success because she was out of an institution. He would find a former patient who was passive and emotionally flat, dependent on family for basic care, and note with satisfaction that they were peaceful and manageable. Freeman's correspondence from his final years shows a man feeling increasingly isolated and misunderstood. Former colleagues avoided him. Medical conferences didn't invite him to speak. The procedure he had championed was now widely condemned. He cast himself as a visionary ahead of his time, persecuted by a medical establishment too conservative to appreciate his innovations. He seemed genuinely unable to understand why lobotomy had been rejected or to accept responsibility for the suffering it had caused. He wrote letters to medical journals defending lobotomy, arguing that criticisms were unfair and that history would vindicate him. These letters were rarely published, and when they were, they generated responses from other physicians detailing lobotomy's failures. Freeman found himself arguing not with colleagues but with a medical consensus that had moved decisively against him. His family relationships suffered. His children struggled with their father's legacy, with understanding how the man they knew could have caused such harm. Some distanced themselves from him. Others tried to maintain relationships while grappling with the moral weight of what he had done. Freeman seems to have been unable to have honest conversations with his family about his work, maintaining until the end that he had helped people. Financially, Freeman struggled in retirement. He had never been wealthy, his focus had been on volume and accessibility rather than profit, and medical practice had been his livelihood. Without income from procedures and with mounting medical expenses of his own, he faced economic insecurity in his final years. This was a bitter irony for someone who had performed thousands of procedures, leaving a trail of damaged patients but accumulating little personal wealth. Freeman suffered a series of health problems in his later years, including colon cancer. He underwent surgery and treatment, experiencing firsthand the role of patient rather than physician. There's no record of him drawing any parallels between his own medical experiences and those of his lobotomy patients, no moment of insight where he understood what he had subjected others to. He died in 1972 at age 76, having lived to see his life's work completely repudiated. His obituaries were mixed. Some focused on his innovations and his sincerity, noting that he had genuinely believed he was helping patients. Others were more critical, emphasizing the damage he had caused and his role in one of medicine's greatest mistakes. The debate about how to remember Walter Freeman would continue long after his death. The counting of the cost. As lobotomy faded from practice, efforts began to understand its full impact. How many people had undergone the procedure? What had happened to them? What could be learned from this chapter of medical history? Establishing precise numbers proved difficult. Record-keeping varied by institution and country. Some procedures were well documented, others barely recorded. Many patients had died or been lost to follow-up. But researchers gradually assembled estimates of lobotomy's scope. In the United States alone, approximately 40,000 to 50,000 lobotomies were performed between 1936 and the late 1960s. The peak years of 1949 to 1952 saw roughly 5,000 procedures annually. These numbers made lobotomy one of the most widely performed psychiatric interventions in American medical history before the pharmaceutical era. Worldwide numbers were even harder to establish, but estimates suggested that perhaps 100,000 people underwent lobotomy across all countries where it was practiced. Some nations performed more procedures per capita than the United States, particularly Sweden and parts of the United Kingdom, while others adopted it more cautiously or hardly at all. The demographic patterns in these numbers told disturbing stories. Women underwent lobotomy at significantly higher rates than men. Roughly 60% of lobotomy patients were female. This gender disparity suggested that the procedure was being used to control women who violated social norms or expectations, not just to treat the most severe mental illness. The socioeconomic and racial patterns were also revealing. While some wealthy and prominent people underwent lobotomy, as the Kennedy case demonstrated, the procedure was disproportionately performed on poor people, institutionalized people, and those without families to advocate for them.